everyone, and welcome to Methylomic Matters, the podcast in which we discuss all kinds of matters regarding the Methylomic project. It's a large European research project aimed at enhancing the effectiveness of the medication in chronic diseases such as Crohn's disease, rheumatoid arthritis, and psoriasis. And this is the first ever podcast made for the general public and patients. My name is Shula Tas, I'm a journalist, and in this episode I will be interviewing Professor of Gastroenterology Gerta D'Haensa, who is also the chair of the Department of Gastroenterology and Hepatology at Amsterdam University Medical Center. And we will be discussing two of the main directions of research, namely Omicron and Epipsora. Welcome, Professor D'Haensa.
Good morning.
Can you explain firstly why exactly are these diseases, the Crohn's disease, the rheumatic arthritis and psoriasis, part of one study?
Well, thank you for this interesting question, and it is indeed a very important question. And we don't have the full answer to it. What we do know is that at the molecular level, Crohn's disease, rheumatoid arthritis, and psoriasis have similarities. So there are molecules that are common to the three diseases that are very important, like tumor necrosis factor, TNF, for instance. But there are also molecules that are pro-inflammatory in one disease, make the disease worse, and anti-inflammatory in another disease. So we have not fully unraveled the full details, but what we do know is that many patients have two of those diseases, or even three. For instance, Crohn's disease and psoriasis can go hand in hand. For instance, patients with spondyloarthritis is chronic inflammation of the spine. When you do a colonoscopy in those patients, you often find subtle ulcerations in the bowel, so they have a mild form of Crohn's disease. So there's a lot of overlap, but we don't understand the full extent at the biological level.
And can you talk briefly about these diseases? What do we see in patients with these diseases?
Well, of course, Crohn's disease is a disease of the gut, so most patients have abdominal pain and diarrhea, but it's not uncommon that those patients also have joint pain, for instance, or ulceration in the mouth, or perianal disease. Patients with rheumatoid arthritis have typically swollen joints and stiffness in the morning, and patients with psoriasis have skin inflammation, but also commonly inflammation of the joint. So there is quite an important overlap, but we try, as doctors, we always try to categorize, and we try to put a certain diagnosis on every individual patient.
Yeah. And what they have in common, as I understand, if I understand correctly, is that they're all chronic autoimmune diseases that cause different
symptoms.
Thank you.
And also the type of population that will have this disease differs importantly. Crohn's disease is a disease often diagnosed between age 15 and 35 on average. Psoriasis, on average, a somewhat older population, more men than women. And rheumatoid arthritis is a disease that hits often after 40, 50 years of age. So the time of the symptom development or the symptom manifestation differs across the three diseases, really.
So the time of the diagnosis differs, and how can you treat patients? What are the current treatments?
Well, fortunately, in the last 3 decades, we have seen the development of very powerful drugs for these three diseases. For instance, it started off with the development of antibodies against tumor necrosis factor, TNF, in the 90s. And intriguingly, antibodies to TNF are active for the three diseases at stake here, for Crohn's disease, also for ulcerative colitis, also for psoriatic arthritis, psoriasis, and for rheumatoid arthritis. So that was really a very successful hit from the beginning.
Yeah.
Later on, other antibodies were developed that were more disease-specific. For instance, vedolizumab only works for Crohn's disease. It's a gut-directed antibody. It will not work for the other diseases. And the latest asset are antibodies to interleukin-23, which is a very important cytokine, a molecule for psoriasis, for instance. But when you block interleukin-23, it also helps for Crohn's disease. So also in the treatment, there is a big overlap among the three conditions that we study in this project.
And if I mean, you are a professor, so you are familiar with these terms, but interleukin-23, can you explain what is that exactly?
Well, interleukin-23 is, we call that a cytokine. And a cytokine is a messenger between cells, okay? And interleukin-23 is the messenger between antigen-presenting cells, so all the antigens that come into the gut from food or from bacteria are presented to our immune system. And that presentation, that is organized by a specific type of cells, the antigen-presenting cells. And they communicate with the immune system, with the lymphocytes, for instance, through interleukin-23. So if you block interleukin-23, that process will be slowed down or even inactivated. And that leads to improvement of inflammation.
And how has treatment improved since biologics have been available?
Well, as I said, anti-TNF agents are extremely effective for the three conditions, but they are not without side effects. And so that is the reason why pharmaceutical companies have developed more novel molecules that are in general safer. For instance, vedolizumab is gut-specific, has very few side effects outside of the gut. Interleukin-23 inhibitors, such as ustekinumab, for instance, are not gut-specific, but are also quite safe. Anti-TNF blockade is associated with an increase of infections, for instance, pneumonia. We don't see that with the newer classes of antibodies. So much of the progress is at the level of safety of drugs.
And is there any knowledge about why some drugs work better than others?
Well, that is exactly the point and the purpose of this whole project. We don't know why certain treatments work better for one patient and worse for another patient. And so we believe that the whole inflammatory umbrella differs among individual patients, and that it's probably orchestrated by how one's DNA is translated into proteins and to inflammatory molecules. What we know about the DNA is that everybody has different DNA, but even, for instance, in monozygotic twins, there are differences. And the differences lie in how DNA is translated into proteins. Okay? So we think that process, which is orchestrated by all kinds of molecules that sit on DNA, usually methylation is called methylation, but there are also other molecules, that determines how the proteins are translated, how DNA is translated into proteins, and that also may determine how you respond to certain individual treatments. And that's exactly an observation that we've done in earlier studies, in the EPIC study, for instance, and that lies the basis of the Methylomic project.
And what is at the base for these trials, at the base of Omicron and Epipsora?
Well, here in Amsterdam, we've been looking at methylation already for over 10 years. And the first observation was that methylation on the DNA was associated with response or non-response to adalimumab, a drug that was very important in those days, one of the only drugs we had. And after that, we took it a step further, and we were supported by the Helmsley Foundation in the United States for that research. We also looked at a phenomenon in ustekinumab-treated patients, in infliximab-treated patients, in vedolizumab-treated patients, and we assembled almost 100 patients treated with every of those individual drugs. We came up with an algorithm that was associated with response or non-response to the treatment. And then we went to Oxford, our friends at the University of Oxford, to see if they could find the same thing in their patients. And that was exactly the case. So that's what we call an external validation. Okay? And now we're going to take the next step, which is prospective clinical validation. And that is the topic of the Omicron trial.
And what were the findings in the EPIC?
Well, in the EPIC project, we were quite surprised that the methylation algorithm was associated with success of individual treatments in over 80% of the patients. And that was strongest for vedolizumab, for ustekinumab, and we're currently working it out for adalimumab and infliximab.
So 80% were effective in
yes. So that
predicting
the hypothesis is that if we now take the DNA of a patient and we look at it and we say, okay, your likelihood to respond to ustekinumab is 83%, and to vedolizumab it's 62%. I'm just saying something. Then we will take the most likely effective drug, in this case, ustekinumab.
And so there's these two projects, the EPIPSORA and the Omicron. And what exactly are you looking at when you're looking at the DNA?
So as I said, we've identified an association between methylation profiles on the DNA of Crohn's disease patients and how they respond to treatment. We want to do exactly the same in psoriasis and in rheumatoid arthritis, because these diseases are very similar to Crohn's disease. So we will recruit patients, take their DNA, follow them, and see how they respond to the most common treatments in psoriasis and in rheumatoid arthritis. In Crohn's disease, we're a step further. We already have that basis, and we're now taking it into a clinical validation trial. And clinical validation trial means that what you've seen in the laboratory, you now will test prospectively in patients. So in the Omicron trial, that's the name of the Crohn trial, it's omic, means that you look at certain biological markers, and Omicron. We will assess the methylation profile of a patient, and we will ask the DNA what is now the most successful individual treatment for this patient according to the DNA.
You will ask the DNA. Can you explain to me, how do you ask DNA?
It's a very smart question. So what we will do is we send the DNA to the lab, of course, because it first needs to be extracted from the blood, right? You have all kind of blood cells. You get the DNA out of those white blood cells mostly, okay? Then you send it to the lab to determine the methylation. So now the lab will measure on these 850,000 genes, where are the methyl groups? Then you receive an enormous data set with that information that no human being can analyze. Okay? So here we need computers and artificial intelligence. And we collaborate with an artificial intelligence lab, Horizon, okay? And they will analyze, they have an algorithm that they developed based on earlier work on the EPIC data, and that algorithm will tell us this is the best patient, or this is a patient best fit for ustekinumab or for vedolizumab. In a later stage, we will probably also bring other treatments on board, such as adalimumab and infliximab, but for now the algorithms are strongest for ustekinumab and vedolizumab, which is nice because these are very safe treatments for Crohn's disease.
Yeah, so you will use AI, artificial intelligence, to help read the DNA so that you can be more effective in treating patients.
Exactly, that's the whole point.
What will this research bring to patients and physicians?
We hope that the trial will be positive and that we can show that methylation is effective in selecting the best treatment for the individual patient. When it works, we will offer this test to the world, to the market, and then it can be implemented across the globe. And what it will mean for patients is that what we currently do, which is a trial and error approach, okay, we think, oh, this is probably the best, or this is, and we give something, oh, this is the cheapest drug, let's give the cheapest. So we will need to move away from that. We will moving towards a biology-driven treatment selection, something that we call personalized medicine. And it's very novel in medicine because there is no approved biomarker test in chronic inflammatory diseases for treatment selection. It does exist already in cancer treatments. Yeah. In cancer, you can investigating the cells, the tumor cells, and you can determine what treatment is needed for an individual cancer patient. But for our field, chronic inflammatory diseases, that has not been done successfully so far.
So it's very exciting new line of research.
Well, of course, it's cutting-edge research, but if nobody does such trials, then we will never have answers to it, right?
And in what time frame do you see, directly benefits for the patients?
Well, the trial has just begun to recruit the Omicron trial, and we're doing this trial in the Netherlands, in Belgium, the United Kingdom, in Italy and in Slovenia, and in Hungary, sorry to forget. And so at 80 sites or so, doctors will recruit patients and invite them to participate in the trial. We need more than 350 patients, so it's a very large experiment. Yeah. And so we hope to have results in the frame of 2-3 years from now. Because not only do we need to initiate the treatment in the individual patients, but also do we need to see has the treatment has its effect in terms of no more symptoms and no more ulcerations at endoscopy. And that all takes time. Besides the treatment selection based on DNA, there also needs to be a control group, because that's how you show that the intervention is better than usual care. Yeah. And of course, and so that is why half of the patients will not receive treatment based on their DNA, but just based on what the doctor usually does, something we call standard of care.
Yeah. And what else can we expect for the future and for personalized medicine?
Well, if this concept works, and it also works for rheumatoid arthritis and for psoriasis, I think we will see many more trials and refining algorithms, so to speak, also for other conditions. There are many other chronic inflammatory diseases like asthma, like atopic dermatitis, like multiple sclerosis, where the same concept will probably be investigated, mechanism.
Thank you so much for your time and your expertise. For more information about Methylomic and other podcasts, please visit www.methylomic.eu.